to UVM to get credit for the hour. Tanya, we can go to the next slide. So the objectives here are to inform you all about this innovative program. The OneCare Innovation Fund in 2019 was designed to try to rapidly test and evaluate innovative programs and interventions, to try to choose projects that would be sustainable, with sort of standing on their own 2 feet without any ongoing need for additional AC funding, to try to create projects that were scalable to other settings and communities from where they were first piloted, and to develop projects that help to address different populations, not only different ages, socioeconomic risks, geography, and conditions. Next slide. So in the first round of the innovation projects, we selected these 3 projects. One is the Youth Psychiatric Urgent Care Model down in Bennington, which was to meet the need of school-age children, for the most part, who were having difficulties in school, and rather than having them sent to the emergency department, United Counseling Services would provide an alternative to the emergency department for helping to address the needs of these children. The community embedded well care is a UVM Children's Hospital program working in a clinic with largely immigrant populations. And down in the Middlebury area, the Ocular Telehealth in Primary Care project was launched, basically putting retinal cameras in primary care offices to provide store and forward retinal images sent to an ophthalmologist to accomplish the need for screening for diabetic retinopathy. Next slide. So we had a second round of projects in the second half of 2019. One of them was a wellness project down in Brattleboro, looking at trying to reduce risks for chronic disease, cardiovascular, and pulmonary conditions. The TeleFriend pilot was a project out of the Brattleboro retreat, basically using tablet-based supportive contact with patients that were discharged from the retreat. And the third column there, the Child Psychiatry Consult Clinic from Community Health Center of Burlington, was basically creating the opportunity for fairly easy access to child psychiatry consultation services. Next slide. The project that you're going to hear about today was also a member of the second round of projects. And this is a partnership between the Howard Center and the UVM Home Health and Hospice entities. And you'll hear all about that during the rest of this hour. The last project in the last column there, the telemedicine and home health for ALS patients. This was basically trying to leverage telemedicine to get these multidisciplinary ALS clinic appointments accomplished for people all over the North Country. These individuals who already have, debilitating ALS would be facing hours of transportation in many cases, both directions, to seek expert consultation from neurology and other disciplines. So this program was felt to be a real aid for getting access to those individuals at a distance. Next slide. So the innovation funds basically had some themes to try to promote in our selection process. And these were to improve access to care, helping with mental health conditions, both prevention, screening, and treatment, to try to get care coordination for high-risk individuals at a higher level of success, looking at improving the health of people with multiple chronic conditions, to try to reduce the incidence of chronic disease, improving the patient experience of care, also transforming systems of care by looking at integrating care across organizational boundaries. So really that multidisciplinary community team approach, using technology, and we had no idea that the pandemic was going to thrust telemedicine and technology so far up the list in ways that we need to address the needs of our patients, and finally to try to eliminate inequalities in healthcare. So these are the themes that we were seeking for the applications. And the next slide, Tanya, I think we're, so let me just introduce Cathie Buscaglia from the Howard Center. She has a very long history with the Howard Center, has been the program manager for the developmental services, but also was the founder of the Safety Connections program, which basically is the supports needed to have people live independently with supports, especially for adults with disabilities. So Cathie, thank you for being here today and presenting. And our second presenter is Jamie McKenzie, a nurse with UVM Home Health and Hospice. She was essentially the founder of the remote patient monitoring Tele-support services through the VNA over quite a few recent years. And she is an expert on deploying telemedicine equipment to get vital signs and other data parameters on patients to support them in their home. So we're very happy to have both of these ladies here with us today. The next slide. We're going to obviously have you better aware of these community supports and look at this collaborative program. So I think without further ado, we'll move on to the presentation. Thank you for being here.
Thanks, Dr. Ward, for that introduction. This is Cathie Buscaglia from Howard Center. And as Dr. Ward mentioned, Jamie and I will be sharing this presentation. I'm going to start with providing a general overview, and then Jamie and I will each review the individual programs of nurse telemonitoring and safety connection that will demonstrate that when we put those things together, we create TeleCare Connection. So TeleCare Connection is an innovative approach to supporting individuals transitioning from the hospital to home. Next slide, please. The learning objectives that we will focus on here today are to understand the importance of having community supports in place for a successful transition to care for patients leaving an inpatient setting, and to gain knowledge on the collaborative project between Howard Center and UVM Home Health and Hospice to provide 24-hour remote support for patients transitioning from the hospital to home. Next slide, please. So the equation that makes up TeleCare Connection is the combination of UVM Home Health and Hospice telemonitoring program and Safety Connection. So each program separately has their own eligibility criteria, but today we're going to focus on the combined criteria for TeleCare Connection. Both of these programs have individually been around for a number of years and independently support patients 365 days and nights a year. And after hearing about the challenges faced by patients without adequate community supports in place who are expressing a reluctance really to discharge home from the hospital, the idea of TeleCare Connection came to us, and it was pretty fortuitous to have the Innovation Fund available for us to test out this idea. Next slide, please. So TeleCare Connection offers home-based care and peace of mind. So this is accomplished through, I think we have to kind of keep hitting these slides, Tanya, to populate the, there we go. Okay, so next slide. So this is accomplished through the delivery of 24-hour remote support to patients in their homes. Next slide. So the benefits of TeleCare Connection are home-based care and recovery, 7-day-a-week health monitoring and overnight check-in service that supports healthy routines and wellness and provides a community of care that focuses on the individual's needs. So eligibility for TeleCare Connection. When you're thinking about referring someone to the program, these are important things to keep in mind. So the individual needs to have stable housing, be eligible for home health services. When we think about folks who who have hospital admissions frequently or use the emergency room frequently, those folks would be good candidates for TeleCare Connection. Folks who can benefit from an in-home telemonitoring support service and require sort of short-term supports for best health outcomes. The TeleCare Connection is a 60 to 90-day transition program for folks who are either discharging from a hospital or inpatient stay to really support them through that vulnerable phase upon discharge. Next slide, please. So the typical patient profile for TeleCare Connection are folks who really feel isolated and lonely and could benefit from a routine check-in. Individuals who experience anxiety and are concerned about their health and well-being. And individuals who are interested in supports that may prevent or delay a higher level of care. We see a lot of people who, after an inpatient stay, are really worried about sort of the loss of skills or their ability to continue to maintain their own ADLs after discharge. And we believe that providing supports at a time when someone is really vulnerable to reestablish their routines can prevent or delay the need for skilled nursing stays or assisted living stays. Individuals who could benefit from knowing support is available overnight when needed. We see a lot of anxiety in this population, worried that when they're home at night and offices and supports are closed for the day, worrying where they're going to get their support from. The TeleCare Connection, although we do provide in-person support when needed, we cannot support people who require routine overnight medical intervention or medication prompting. So if there's an individual who needs something on a scheduled basis every evening or every morning, we cannot provide that service. But we do offer, and we'll talk more about this a little later in the presentation, we do offer in-person support for situations that are unanticipated that arise for our participants. And we really look for folks who don't engage in behaviors that put others in danger. Again, we have our staff going into homes and we want to ensure that they're going into a safe environment. Next slide, please. Some disqualifying factors for folks in TeleCare Connection. So if someone is physically unable to use the monitoring equipment and they do not have a caregiver available to assist them, they would not be an appropriate referral for TeleCare Connection. If they do have someone in their home that can help them use the equipment, we would consider them for the program. Another disqualifying factor would be someone who has a cognitive, behavioral, or safety issue, and again, does not have a caregiver available to mitigate that and support them. Folks who have a history of non-adherence to service provision due to active alcohol or drug use and abuse would not be an appropriate referral. Again, this is not to say that patients who engage in alcohol or drug use would not be eligible. We're really speaking to someone who has really a clear history of non-adherence to services due to those conditions. And if a person is homeless or has a physical environment that would not be safe to provide services for, we wouldn't be able to support them. Again, this is a home-based support program. And if they did not have access to a phone line, oops, we got a lot of feedback there. We couldn't support them. Some of our technology requires either a landline or cellular service to operate. Next slide. So how it works, the nuts and bolts of TeleCare Connection. We can move on. So as I mentioned earlier, that this is a transition program. So we offer this program for 60 to 90 days as individuals are discharging from, wow, I'm getting some feedback. I don't know if maybe everybody can mute. That might help. Well, that's a little bit better. Whoops. Did we lose our slide place? There we are. Okay, here we are. So 60 to 90 day support program as folks are transitioning out of the hospital. And again, you know, this is a very client-centered program, and so we really work with individuals and their care teams to identify the best course of support for that individual, whether it would be 60 days or 90 days, and work with them to ensure that their needs are met during that time. And so as we've talked about, that this is sort of the marriage of the home health and hospice telemonitoring support program and the safety connection Howard Center overnight support program. I'm going to just hit some highlights here of what each of those programs provide. And then Jamie will go in more details about the telemonitoring support. So telemonitoring support offers access to a triage nurse 24 hours a day, 7 days a week, with telemonitoring nurse support available daily from 8 a.m. to 2 p.m. And the patient's condition is monitored daily through their vitals and Q&A that's transmitted by a tablet in the patient's home to the nurse monitor. The equipment is an easy in-home setup and pretty intuitive for the patient to use. And we offer care coordination for best patient outcomes. And then the Safety Connection overnight monitoring portion of TeleCare Connection is provided from 8 p.m. to 7 a.m. And we provide a nightly check-in with the Safety Connection operator. We offer our community of care responder, and we provide after-hours emergency care coordination. So I am going to pitch this to Jamie, and Jamie can speak to you about telemonitoring for the next few slides.
Great, thank you, Cathie. So my name is Jamie McKenzie. Good afternoon, and I'm a nurse at UVM Home Health and Hospice, and my role currently is telemonitoring nurse coordinator. I'm going to talk briefly about how the daytime telemonitoring piece of this program can provide support for patients. Our experience at UVM Home Health and Hospice using telemonitoring with our adult home health services is that it has provided two primary benefits. First, it provides patients the comfort of knowing a nurse continues to monitor their health status on a daily basis after returning home from a hospital stay. which bridges the gaps between the clinician home visits, since they will also be receiving home health services. Second, it engages patients in learning to better manage their health and recovery after acute illness or surgery, which supports the overall home health goals towards self-management. Typically, we offer telemonitoring to patients based on certain diagnoses that are considered to put patients at higher risk for rehospitalization, such as heart failure or COPD, among others. But there will not be any diagnosis-specific criteria with this TeleCare Connection program. So that's what makes it different from our typical telemonitoring. As Cathie mentioned previously, the hope is that telemonitoring support during the day, in combination with the safety connection support overnight, will provide comfort for patients who are anxious about coming home. So the biometrics that we can monitor through our telemonitoring program include blood pressure, heart rate, SpO2, weight, glucose, and temperature. These biometrics can be individualized based on the patient's needs and abilities. For instance, if they don't need to collect a daily weight, for instance, or are not able to safely collect a daily weight, then we don't set it up in that way. So we could customize it so that we're only monitoring the items that are necessary. We can use customized medication reminders to enhance the monitoring. And every day the patient is asked to answer survey questions that help to support early identification of complications. But all of these survey questions are customizable so that as we get to know the patient and their needs more and their symptoms that they're experiencing more, we can customize that to better serve them. We can also customize reminders that they need other than medication reminders, and also provide intertwined in the surveys that they receive each day, patient education in the form of health tips that they can read and short video clips. Next slide. So this is showing the equipment that we provide to patients to use in the home. On the left there, you see there's a digital scale, a pulse oximeter, and a home blood pressure cuff, along with a small Samsung mini tablet. It does not come with a glucose monitor or a thermometer, but the patients can manually enter these results from their own devices. So the devices that we offer, though, have Bluetooth capabilities so that the results are transmitted to that tablet, and then using the cellular connectivity, the tablet sends all of the results, including what the patient has manually entered for survey answers and their from their other devices. That is transmitted into a web-based portal for a nurse to review. Next slide. So this, when we first install the equipment, we a mutually agreed upon daily monitoring time is set, ideally earlier in the morning, ideally between 9 and 10, but we work around patients' morning, routines. And that time each day, the tablet lights up like you can see here, and along with the subtle bell tone, acts as a reminder that it's time to do their biometric testing or their monitoring. Okay, next slide. So this is an example of some of the medication survey questions that we ask and reminders that we can provide. So the question on the left, you can see we use this one a lot with good success. Do you have all your medications to get through the weekend? If they were to answer no, that answer would trigger an alert to a nurse who would then call and follow up with the patient to make sure that they don't, to see if they were able to manage that on their own, to get the refills needed, and if not, we can provide help and support to do so. And then on the right, you can see, have you done your Spiriva inhaler this morning, yes or no? So that was a specific patient was having trouble remembering that particular medication, and this helps that person to develop the routine to take, remember to take that each day. Okay, next slide, please. Individual survey questions. So this is an example of a survey question that we use to try to determine if patients are having symptoms that we would want to be concerned about and follow up on. These questions change each day of the week and then repeat the next week on the same day each week. So the nurse is able to look back and compare answers, which help us to determine if a patient is developing acute symptoms or if this is a chronic status for them. And then again, we can customize these questions as needed. Okay, next slide. We also have the ability to do a video call or a video visit with a patient. This, helps the patient to develop a higher level of comfort and security with the face-to-face contact, and then allows also the nurse to be able to visualize if there are issues happening, to do a further assessment of the issues in that way. So this works with Zoom. Zoom is the platform that works behind the scenes here, and it's very simple to use in that the nurse from the portal just can initiate a video call to the patient, and the patient would hear and see on their tablet screen, it sounds like an old-fashioned telephone ringing, and they would see an icon that says either reject or accept, and all they would have to do is tap on the accept, and they would then be able to see the nurse, and the nurse would be able to see the patient. One of the additional features that we've been using, especially with this pandemic occurring, is the ability to conference in other care team members by, in real time, learning the Zoom meeting ID, and then we can forward that to another care team member or a caregiver, a remote family member, a doctor, whoever may benefit from being involved in a video conference with the patient. Okay, next slide. So just in summary, the benefits of telemonitoring are monitoring between the clinician home visits to keep a closer eye on potential, catching potential problems earlier, develops a daily routine for health management, reinforces education on health management, and provides trended data for field clinicians and doctors as needed, promotes greater patient engagement and patient satisfaction. And so that's a summary of the telemonitoring. Cathie?
Thanks, Jamie. So It's important to know that since we have two sort of separate service providers coming together to offer this combined service that we call TeleCare Connection, that both services coordinate care for the patient by communicating daily about the patient's needs or challenges. There's a daily note that's generated after each overnight shift, informing the telemonitoring nurse and any members of the patient's care team about their needs overnight that Safety Connection responded to. In turn, the telemonitoring nurse informs the Safety Connection operator of any issues or concerns that the patient may have had during the day that should be followed up during the overnight. So this communication provides the patient with a sense that the staff that are interacting with them are informed and up to date on what their care needs are. So in terms of the Safety Connection piece, Safety Connection delivers overnight, person-centered, independent living support to people who want to live on their own. Next slide, please. So Safety Connection has a sort of another set of technology that participants use in their home. And this personal emergency reporting system, or PERS technology, is what provides the connection to Safety Connection staff during the nighttime hours. So this technology is universally designed and easy to use. It offers advanced fall detection to the participants and an array of personal help buttons. And you see the buttons there pictured below the panel. And the participant can choose to, use any one of those buttons. They can have it on their wrist as a bracelet, or we have lanyards that people can wear around their neck. And included in these personal help buttons is fall detection. So if a person wanted to have fall detection, they would have that embedded in that button. We also offer smoke and freeze detection with this PERS unit, and it's been really interesting to learn some of the habits of our Safety Connection participants, particularly in the wintertime when people go away for the weekend. We've learned that many people turn their heat down or turn their heat off to the point where our operators are getting freeze alarms from those homes, and we've been able to work with people to sort of moderate how low they turn their temperature down when they leave the home. Oops, I'm getting a bunch of feedback again, I don't know. So this unit operates with hands-free two-way voice communication. And so is everybody hearing this terrible feedback? I don't know if people can mute.
Can everyone please mute? Thank you.
Okay, let's see. Maybe that's better. No, not really. Is that gone now? Should I keep going, or is this? Okay, let's try this. So the unit is a hands-free two-way voice unit. And so when our participants check in at night, and we'll talk a little bit more about the check-in process, is they can either check in by pushing that large white button on the panel under the word help, or they can use their help button to push the button to signal the operator that they're checking in for the night. So once an alarm comes into our operator station, the operator opens up two-way voice communication, and you see there's a speaker in that upper left-hand corner of the panel. It's very audible, quite loud, and our participants haven't had any trouble hearing from one room in the apartment to the other or speaking to that panel. And then we, as I mentioned earlier, need a landline or cellular service in order to activate this panel from a participant's home. The next slide, please. So this is our Safety Connection service model. And as I mentioned earlier, from 8 p.m. to 7 a.m. are our service hours. And as we see on the left under the monitoring service, we have an operator sitting at a computer station. Our participants have panels in their individual homes and apartments around the community. And then we have our community of care response team. And so, as I mentioned earlier, we are a very person-centered program. And so when our participants each have a check-in time nightly, and we work with them to identify what the best time is for them. So some people like to start right at 8 o'clock. Some people are night owls and prefer to check in at midnight or later. Whatever the participant's check-in time is, they would send a signal to the operator station by pushing their pager or their panel button. The operator would open up two-way voice communication with them over their panel. There's no need to pick up a phone or dial a number. If I'm the operator and Mary is the participant and her check-in time is 8 o'clock, she sends me a signal at 8 o'clock. I see on my computer screen it's her. I open up two-way communication and I might say, "Hi, Mary, this is Cathie. I'm the operator tonight. How was your day?" We may check in about, maybe there was a sporting event she watched or something she's interested in, and we have a quick check-in. And then from that time on, her system is armed and ready to go. And so if she has a need, she can push her pager. If she falls, I will get a signal. Our fall detection is quite sensitive, and we've learned that we have a lot of participants who seem to flop down into their, recliner or what have you. And we find that our operator will get a fall alert and check in with the participant, and they're like, "Oh no, I just, sat down in my chair." And sometimes we, have true falls where we respond to. So the majority of our services to our participants and supports are served in what we call over-the-air support. So the majority of the concerns or issues that come into our operator are solved just by talking to the person over the air. If we do have a situation where one of our participants requires an in-person response, the operator has our community of care response team that can be deployed to the individual's home to provide in-person response to support them through whatever it is that's going on. So they'll go over and help them with whatever the issue was and then leave. And we do have times when our participants require, emergency medical services, and anytime 911 is called, we dispatch a responder to our participants' home to support them through that sometimes, difficult situation of having EMS coming into their home and having them understand and be supported through that. So that's something that we offer as well. Next slide, please. So our community of care response team, our operators and our responders are experienced clinicians who, as I mentioned earlier, employ a person-centered care practice. They're skilled in emotional and behavioral support strategies. And like I said, the bulk of the work that we do to support our participants is done over the air and sort of informal counseling. We provide problem solving and guidance support based on a relational approach. And it really is interesting how relationships are developed with folks. Our operators don't actually see our participants, our responders go and do in-person support, but our operators are really, a friendly voice on the other side of the line each night, and relationships really do grow from that daily connection with the person. And so our team is always ready to deliver an over-the-air outreach or an in-person response when that's needed. Next slide, please. So loneliness and isolation have become a hot topic lately. And the incidence of loneliness was recently called an invisible epidemic by the former Surgeon General Vivek Murthy. So since 1980, the number of adults who report feeling lonely has doubled from 20% to 40%. And the lack of social connection has been found to increase health risks. And they're saying that those health risks are equal to smoking 15 cigarettes a day or having an alcohol use disorder. Social isolation or loneliness is a major concern for people who are living alone. And feeling lonely is connected to developing a generalized anxiety disorder. And in these days of social distancing, loneliness will likely increase, leaving many people feeling like they're struggling and alone. TeleCare Connection service, which provides a daily check-in from a trusted support, could make a significant difference in how people feel returning home from an inpatient hospital stay. Next slide, please. So we like to say, I think if you click that again, I'll get my little pictures. Safety Connection, we like to say Safety Connection brightens up the night. And as I mentioned, we work with our participants to establish a nightly check-in routine. And as I mentioned, you know, we work with the person for what time is best for them to check in. If we have a participant who does not check in at their designated time, our operator will reach out to them to make sure that they're okay, and hopefully they just forgot to check in. If they do not respond to our outreach, we'll send a community of care responder to their home to make sure that they are in fact okay. And we do community of care responder outreach. If we have a participant who's maybe had a particularly difficult day and we've heard from our telemonitoring nurse that maybe this person needs a little extra support that night, we will plan to give them a call to check in or arrange for an in-person outreach from our responder just to ensure that they have that little extra support that they need to get them through whatever that rough patch is they might have. You know, help is needed help is there when people need it most. We kind of hang out in the background, and when people need us, they can reach us. We provide emergency response coordination, as I mentioned earlier. If we're sending emergency services over, we would always send a responder over to support that process. And we provide supportive relationships for folks who may not have a lot of connections in their lives. Next slide, please. I think you have to hit that a couple times to get all my stats in there. So, you know, some of the data that we've gleaned from our Safety Connection participants from our consumer satisfaction survey, 83% of Safety Connection users report satisfaction with their living situation. 90% feel safe at home during the night. 88% of Safety Connection meets their needs even when they change. And 95% say, I can always get help at night when I need it. I think you got one more in there to click on. There it is. Next slide, please. So TeleCare Connection's mission. So to support patients' recovery at home, to avoid unnecessary use of higher levels of care, to provide social and emotional support, to combat loneliness and isolation, and to empower participants to live their best lives. So next slide. So that's the TeleCare Connection story. And Jamie and I would both be happy to answer any questions that anyone has.
This is Norm. If people would like to, type in the chat, or if you want to unmute and ask a question, that would be fine.
Currently, there are no chat questions. I can try to unmute folks and see if we have any folks who'd like to ask questions that way.
While we're waiting for other questions, this is Norm again. So in your estimation, what is the ideal type of patient being discharged from the hospital that would be appropriate for this program?
Sure, Norm, this is Cathie. So the ideal patient is, someone who has some anxiety about being discharged, who maybe calls emergency services because they're worried, because they don't have someone to support them at night. We really do offer support to people. People think they need something when maybe they don't, and they worry unnecessarily. And so we have found, certainly through our Safety Connection service, that folks just knowing that there's someone there every night that they're gonna talk to, that they could reach out to at any time, offers a lot of support and prevents some unnecessary use of emergency services.
There was a question in the chat box about limitations on geographical areas.
Yes, so interestingly, we've had some interest from folks in Addison County for this service, and we're fairly limited to Chittenden County at this point, although we would be willing to partner with other organizations outside of Chittenden County. For the in-person response is really what limits our geographic response. So for instance, Safety Connection in its sort of true form outside of TeleCare Connection, we do provide that service across the state in partnering with other designated agencies to identify a responder. And so our operator will dispatch the local responder if there is a need for in-person support. So we do have some flexibility, but TeleCare Connection is really sort of focused on Chittenden County at this point.
Cathie, this is Susan Shane, and I may have missed this. I signed in a bit late, but what is the funding mechanism? Do we need to think about referring individuals with certain insurance plans?
So right now for the TeleCare Connection project, this is funded through the Innovation Grant. So right now there isn't a cost to patients to participate.
Wonderful. And the referrals are, did you mention how referrals are made or how people connect with you? So
referrals, so when we originally came up with this structure, referrals were coming primarily from, were anticipated to come primarily from UVMHN. And so our the home health and hospice liaison, Deb, who is at UVMHN, was the primary sort of referral to Jamie. So, but, Jamie and I have both received emails from people and would be willing to sort of shepherd a referral through the process as well.
Thank you.
This is Norm. We have some additional questions. One was, has this model of care been trialed for hospice patients as well?
we have not. And Jamie, I don't know if you can speak to hospice patients using remote support.
We have not either. No. So that is an area where we have not gone into.
Which I think is a super interesting idea, whoever asked that question, especially during these trying times for a family who has a patient who's dying at home, to have support available through this technology could be a really innovative idea.
Mm-hmm.
There was another question about how is the safety connection equipment set up in the patient's home?
So the safety connection equipment is set up by plugging into either a landline or connecting to cellular service. So it is really plug and play. It's not very high tech to set up or to train an individual participant to use.
And for the telemonitoring, we have a tech who's dedicated to going out to bring the equipment and help to set it up and do some training with the patient and or caregiver on how to accurately use all the equipment and practice a bit so that they're comfortable.
There was another question about the nature of the medical backup. Should the needs of the patient exceed the on-call expertise, but is not the level of a 911 call? Do entities have contingencies for that type of elevated concern?
So for the overnight hours when Safety Connection, who are not medical professionals, are on, we do have access to the 24-hour nurse through home health and hospice for any consultations.
This is Norm. I had another specific question about you can obviously get pulse rates on your telemedicine equipment. Is there any capability for actually looking at rhythm strips, or is that not a technology that has happened yet?
Unfortunately, we don't. It does not. It's not possible through the equipment that we use now. And so the answer, the short answer is no. Yeah. I mean, I think for that type of, there would be ways to add that on through different event monitors, but it wouldn't be monitored through us. It would be a different vendor. Yeah.
Another question asks, how does the notations, how do the notations concerning the monitoring make it to the medical record or to the primary care clinician?
Well, for telemonitoring, it would work in the same way that it would for all of our other telemonitoring patients, in that, in a variety of ways. Either we would reach the doctor by telephone, and depending on the office, we can send affiliate messages if it's a UVM affiliated doctor through Epic, and then we've developed a process to email daily updates between the Howard Safety Connection and the telemonitoring nurse each day. Does that answer that question?
I think so. I think I had a fax in my mailbox, kind of a summary document of some telemonitoring data.
Yes, thank you for reminding me of that. So yes, we can fax trends as well. And, but when we're doing a fax, we're also sending a message to highlight that you should look out for the fax, and provide some other detailed information about the reason we're sending the fax.
This is Norm. I also have a question about whether or not the technology has grown to include sort of automatic medication reminders to the patient, kind of a ringtone or something. You know, did you take your metoprolol this evening? Can that be automated?
Yes, we can automate it for them. You know, we can customize reminders and then add the specific times of day that they need the reminder. Yep. And then that would be automated each day. Yep. We've done that for a variety of, you know, things. We have another example of reminders outside of medication. Reminders is like a person who's new on tube feedings, for instance, and forgetting, you know, to do their tube feedings and to flush their tubing, and those kinds of reminders. We can set automatic reminders that would look and present to the patient just like the reminder in the morning to do all of their monitoring. It would be a visual light that comes on and a audible dinging to remind them.
So this is Norm. So I think Tanya has displayed the QR code here. So if you wanted to take a smartphone picture of that, that would take you to the UVM CME claiming credit site. Otherwise, I think we will be sending the link to CME out to participants, as well as the slide deck. So I really want to take this opportunity to thank both of you for your great presentation today. I hope that one of the outcomes of this presentation is advertising the availability of the program and helping to get this top of mind for, you know, kind of difficult discharges that would be facilitated by people understanding that this type of service is available. So thank you all very much and have a great afternoon.
Thank you. Thanks for having us.
Thank you.
Bye-bye.